In KEYNOTE-756, patients were randomized between a backbone of chemotherapy with the regimen paclitaxel 12 weeks, followed by 4 cycles of anthracyclines, and were randomized between um, adding pembrolizumab or placebo. This was a double-blinded phase 3 randomized trial. Very importantly, this trial has two primary endpoints. One is PCR rate, and the other one is event-free survival. It's also important to characterize the type of patients that entered the trial. So this trial was for high-risk early breast cancer, defined as T1C, T2 with positive nodes, so N1 or N2, or T3, T4 with either N0 until N2. All tumors have to be grade 3 and obviously no treatment naive. So 1,278 patients were randomized, and there were several stratification factors. It's also important to know that this trial is powered to detect a difference both in PCR and event-free survival. And actually, the alpha was split between the two, 0.5 for PCR, 2% for EFS. And if PCR is positive, as it was the case, then the alpha is transferred for event-free survival. And if event-free survival is positive, it will be transferred to overall survival. In the characteristics of the patients in general, highlighting that about 35% had T3, T4 tumors, 90% had node-positive disease, 75% PDL tumors were PDL1 positive, and the vast majority, 95%, had ER positivity above 10%. So the ER low population represents only 5%. So this analysis that was presented at ESMO is the final analysis for PCR. It was run with a cutoff data of May 2023. At the time, 10 months after the last patient was randomized, all patients had gone through the neoadjuvant phase, and only 58 patients were still on treatment in the adjuvant phase. It was also the first interim analysis for event-free survival, but these results were not released by the IDMC. Regarding the PCR rate, we have seen an increase with the addition of pembrolizumab with a delta of 8.5%. So from 15.6 to 24.3%, according to the definition of PCR, the benefit was seen with or without DCIS included in that definition with a similar magnitude. In terms of subgroups, in all subgroups, there was a benefit with the addition of pembrolizumab. There was no subgroup where we wouldn't see this benefit, including in PDL1 positive and negative, albeit the magnitude of benefit is bigger when PDL1 is positive. And also regarding this population of ER low, we see what seems to be a bigger benefit, but with a very large confidence interval due to the fact that this represents only 5% of the population. For safety, we have not seen any new safety signals. We see in the neoadjuvant phase, the majority of side effects are chemotherapy related, with some small differences between the two arms, with a slightly higher discontinuation rate in the pembro arm. Only one death related to myocardial infarction considered by the investigator related to chemotherapy. In what concerns the immune-mediated events, nothing also new here. The majority were hypo or hypothyroidism, as it would be natural, since what we know about pembrolizumab, very small percentages of the other immune-mediated events, no deaths, and a slightly higher discontinuation rate in the pembrolizumab arm. So in conclusion, we can say that KEYNOTE-756 is the first fully accrued phase 3 randomized trial of immunotherapy in high-risk early breast cancer with ER-positive, HER2-negative tumors. It met its dual primary endpoint PCR um, with a statistically significant increase of 8.5%, regardless of PD-L1 status. No new safety signals were seen, and we continue to have follow-up, and the study continues to be powered to test event-free survival as a primary endpoint, and follow-up will continue, and more results will be presented in the future. We should not change our standard of care based on PCR alone. In my perspective, we should not change in any subtype of breast cancer, but in particular in this subtype, we need to have the event-free survival data before we change the standard of care. However, in the same session, another study was presented also with immunotherapy in a very similar population with a different agent, and the same results in terms of PCR was seen. So we have a consistency of increased PCR rates in this high-risk early breast cancer, ER-positive, HER2-negative. So we can have some hope that we will see an impact in event-free survival. It will depend on the analysis, but in principle, in about 1 or 2 years.